Mood disorders and schizophrenia. Introduction. Most people will experience mood changes from time to time. Temporary changes in emotion, thoughts and behavior are normal. For example, you may feel low and stressed during revision but become elated when your results are announced. You go out to celebrate, spend too much money, act impulsively and regret your behavior the following day. Less frequently, people experience severe, sometimes long-term, mood and behavior changes, requiring the help of a mental health professional. Doctors and psychiatrists use a manual, listing symptoms, to make a diagnosis. The International Classification of Disease, Injuries and Causes of Death, ICD, used in Europe and the UK, covers both physical and mental disorders. The Diagnostic and Statistical Manual, DSM, used extensively in the USA, covers only mental disorders. Information about mental health problems is very similar in each of the two publications. Unipolar and bipolar depression. One mood disorder listed in both the DSM and the ICD is unipolar depression. This is the term used when a person's mood changes from normal to depressed. It can range from mild to severe, and is categorized as a neurosis. People suffering from unipolar depression are usually aware of their mood change and will either spontaneously recover or voluntarily seek help. A second type of depressive illness is bipolar disorder. Bipolar disorder is characterized by a mood swing from a very low, depressed state to a mania. About 1 in 10 people diagnosed with clinical depression find that when the depression lifts, they enter a period of extreme elation known as mania. Bipolar disorder is therefore characterized by mood swings. During the manic phase, the person may lose touch with reality and the illness is therefore categorized as a psychosis. Symptoms of unipolar depression. Depression can affect the thoughts, cognition, feelings, emotion, behavior and physical well-being of an individual. Cognitive symptoms. The thought processes of a depressed person are often impaired. Memory and concentration can be affected. They can find it difficult to think in a positive way about themselves or their future. Sometimes, the person will experience persistent worrying without any obvious cause. They may think about committing suicide. Emotional symptoms. A depressed person often has feelings of sadness and despair. Some people might experience an absence of feelings and describe themselves as empty. They may have no interest or pleasure in everyday activities, as if they can't be bothered. Feelings of excessive guilt, about real or imagined events, can also occur. Behavioral symptoms. A severely depressed person can stop socializing, lose interest in sex and stop taking care of themselves. Everyday activities may take much longer to complete. They may attempt suicide. Physical symptoms. Doctors believe that around 40% of people suffering with depression visit their surgery for the first time because of physical symptoms. These include aches and pains, a lack of energy, palpitations, headaches and stomach upsets. Sleep disturbance is another possible symptom. There can be a loss of appetite and weight. Diagnosis of unipolar depression. Unipolar depression may appear gradually or suddenly. It occurs in all social classes and at all ages, from childhood to old age. The severe forms are more common in middle and old age, although there has been a steady increase in depressive illnesses amongst people in their 20s and 30s. Before a diagnosis of depression can be made, the symptoms, which might be a combination of those listed, should have lasted for at least 2 weeks. Symptoms of bipolar disorder. When depressed, the sufferer experiences similar symptoms to those present in unipolar disorder. The symptoms described below appear when the person enters the manic phase. Cognitive. The thought processes of a person in a manic state can be quite severely disrupted. They can have delusional ideas, believing, for example, they are a famous person. This is known as a grandiose delusion. They may think that other people are trying to harm or kill them. This is known as a persecutory delusion. Sometimes the person may hear voices inside their head or have visual hallucinations. They may also make reckless and irrational decisions, showing little regard for the effect of these on others. Emotional. A person in the manic state will feel marvelous. They will therefore strongly deny that there is anything wrong with them, because they feel so good. They may become irritable with those around them who attempt to intervene. There can be a loss of social inhibitions and a lack of guilt. Behavioral. There is often a marked increase in work, sexual and social activity. The person may become more talkative and speak faster. They may become reckless, with negative consequences. Physical. During this phase the person will tend to sleep very little and have an increase in energy levels. Diagnosis of bipolar depression. This disorder, which is sometimes called manic depression, affects about 5 people in 1,000, with equal numbers of men and women. Symptoms of both depression and mania must have been experienced for a diagnosis to be made. Patients may be unaware that there is anything wrong during the manic phase. In serious cases, they may be admitted to a psychiatric unit for treatment without their consent, under an assessment order of Section 2 of the Mental Health Act 1983. Evaluative comment. While the DSM and ICD enable practitioners to diagnose a mood disorder on the basis of symptoms experienced, there are no physical tests to establish signs of disease or illness. For example, a broken bone can be confirmed by using an X-ray. Mental health problems are more difficult to diagnose because they are based on self-report from the patient. Another important difference between diagnosing physical illness and mental disorder is the etiology, cause of the disease. Physical illnesses, like an outbreak of Legionnaire's disease, can be traced to the cause, most recently in the UK, a faulty air conditioning system. As you will see throughout this chapter, it is much more problematic for mental health practitioners to establish, or agree on, the causes of the disorder. Seasonally affective disorder. Seasonally affective disorder, SAD, is a type of depression occurring in the winter months. For some people, the illness is very severe, preventing them from functioning normally. SAD can begin at any age, but the main age of onset is between 18 to 30 years. It can be either unipolar or bipolar. Unipolar SAD will end in spring with a return to normal functioning. With bipolar SAD, the sufferer enters a manic phase when winter ends. The condition is usually diagnosed when the person has had 3 or more consecutive winters of symptoms. The pineal gland in the brain secretes a hormone called melatonin when it begins to get dark outside. The hormone acts to make us feel drowsy and ready for sleep. This biological influence may explain why SAD occurs. People who are sensitive to seasonal changes in the intensity and duration of daylight may be more prone to SAD. Study 1. The AIM. Terman, 1988, tried to find evidence that a reduction in daylight hours contributed to SAD. Method. He compared the incidence of depression in 2 parts of America where daylight hours were different. Result. He found 10% of people living in New Hampshire, where the winter days are very short, suffered from SAD. In Florida, which has more daylight during winter, the incidence dropped to 2%. Conclusion. The difference in daylight hours was a contributory factor in the onset of seasonally affective disorder. Evaluative comment. Other studies have highlighted the impact of changes in geomagnetism as an explanation for SAD. Whittle, 1995, noted that suicide rates for young people in Alaska are 6 times higher than the U.S. average. He suggests that the aurora borealis, northern lights, over Alaska, which causes changes in direction of the magnetic field, may be a contributory factor. Support for the importance of daylight is evidenced in the success of a treatment method known as phototherapy. Barlow and Durand, 1995, found the condition can be eased by exposure to very bright light, at least 10 times the intensity of the domestic light bulb, for up to 2 hours a day. Light boxes have been developed for this purpose, but are not yet available on the NHS. They cost about £100. However, phototherapy is a time-consuming and often inconvenient treatment method. It can cause headaches and eye strain in some people. Seil, 1997. Another, even more expensive, alternative is to head for sunnier climes during winter. Treatments for mood disorders. The biological approach. Biochemistry. The brain produces chemicals to pass messages between different parts of the brain and the nervous system. These are known as neurotransmitters because they transmit messages between neurons, and are proposed as a possible cause of depression. The amount of certain neurotransmitters in the brain may be reduced during depressive episodes and increased during periods of mania. 2 neurotransmitters implicated in mood disorders are noradrenaline and serotonin. The brain deactivates the neurotransmitter substance, once it has passed on the neural message, in 2 ways. Either an enzyme, monoamine oxidase, is produced, which breaks down the chemical messenger. The neurons then have to produce more substances ready for the next firing, or the neurotransmitter is reabsorbed into the neuron that produced it. This process is known as reuptake. If reuptake does not occur, more substances must be produced. Study 1. The AIM. Support for the biochemical approach was provided by Tuting et al., 1981. Method. A compound, produced when noradrenaline and serotonin are broken down by enzymes, is present in urine. Tuting analyzed and compared urine samples from depressed and non-depressed participants. Result: depressed patients' urine had lower than normal levels of the compounds. Conclusion: this suggested that depressed people have lower than normal activity of the neurotransmitters in the brain, which causes the depressed mood. Evaluative comment: one difficulty with the biological approach is whether we can establish causality. Do lower levels of neurotransmitters cause depression, or does depression cause a reduction in neurotransmitters? The approach focuses largely on internal, physiological factors. However, depression may be a reaction to external life events, such as bereavement. Biochemical treatment. One of the main advantages of the biochemical explanation is that it has enabled researchers to develop successful psychotropic drug treatments for mood disorders. These drugs are specifically designed to affect mental symptoms. Antidepressants are frequently used in the treatment of moderate to severe unipolar depression. Early treatments known as triclic antidepressants were discovered in 1958. These drugs prevent the reuptake of noradrenaline and serotonin, causing an increase of these substances in the brain. They were seen as a major breakthrough in the treatment of mood disorders because they reduced the number of hospital admissions, allowing people to visit their own GP and self-medicate. Another class of antidepressants are the monoamine oxidase inhibitors, MAOIs. The drug works by stopping monoamine oxidase so that the levels of serotonin and noradrenaline in the brain increase. MAOIs seem to work better for some people than tricyclics. A third and more recent class of antidepressant has been developed, known as selective serotonin reuptake inhibitors, SSRIs. As their name suggests, they selectively target serotonin, by stopping the reuptake process, thus increasing levels of serotonin in the brain. A well-known SSRI is called fluoxetine, Prozac. Antidepressant drugs can be effective in the treatment of unipolar depression caused by low levels of certain neurotransmitters. However, in bipolar depression, it is likely that during the manic phase, the mood change is caused by an increase in levels of biochemicals. In 1949, it was discovered that a simple chemical compound, called lithium carbonate, could control the major mood swings of bipolar depression. Lithium occurs naturally in small proportions in much of our food. While scientists are not yet certain how the drug works, it is thought that it acts by affecting another neurochemical, which can either increase or decrease neural activity. Davison and Neal, 2001. Evaluative comment. All antidepressants take some time to work. Interestingly, the increase in neurotransmitter substances occurs as soon as the patient begins to take the drug, but the effects are not felt immediately. Sterling and Helliwell, 1999, argue that the drugs work not by increasing the amount of the neurotransmitter, but because they eventually alter the sensitivity of the receiving neurons, making them more effective. Additionally, drug treatments do not always work. For example, some people with bipolar disorder report no change in manic episodes whilst taking lithium carbonate. In unipolar disorder, there can be variance in individual tolerance. The patient may have to try lots of different types of antidepressant before they find one that suits them. Drug treatments have an added disadvantage because they can produce side effects. Study 2. The aim. Price, 1968, wanted to provide evidence of a genetic cause for bipolar depression. Method. He looked at sets of identical, monozygotic, or MZ, and non-identical, dizygotic, or DZ, twins. As the identical twins shared 100% of their genes, it was expected that they would have very similar psychological functioning. This similarity is called a concordance rate. There should be a lower concordance rate for DZ twins as they only share, on average, 50% of their genes. Result. Price looked at 97 pairs of MZ twins who had been raised in the same family and found a concordance rate for bipolar disorder of 68%. The concordance rate for MZ twins who had been raised apart, 12 pairs, was almost the same, 67%. In 119 pairs of DZ twins, as expected, the concordance rate for bipolar disorder was lower at 23%. Conclusion. This shows that biology and not other social factors, like being raised with an identical sibling, is a major contributory factor in bipolar depression. Evaluative comment. While Price's study does provide evidence that genetic factors are important, if it were a wholly genetic disorder, the concordance rate for MZ twins should be 100% and for DZ twins 50%. Other factors must be involved, to make the affected twin more vulnerable, or to protect the non-affected twin. There have been fewer studies exploring the genetic contribution in unipolar disorder. Most research suggests that other social factors, such as unemployment, divorce, or caring for small children in difficult circumstances, may be more important. Brown and Harris, 1978. These factors may also explain how some people appear to have a genetic predisposition, inherited tendency, to bipolar disorder, but do not develop it. While research into the role of genes is ongoing, the approach does not as yet provide a method of treatment. Psychodynamic approach. Freud, 1917, thought that the symptoms of depression were very like grief. Mood disorders could be traced back to early childhood, when the personality was being formed. If the child experienced some form of loss, real or imagined, during these years, he or she would experience feelings of desertion and rejection when faced with loss in adult life. This re-experiencing of childhood is known as regression. The relationship with parents during early childhood can cause the child to feel hostile towards them. Even the very best parents cannot satisfy the needs of a demanding youngster all the time. These feelings would cause conflict within the child. To overcome this, anger is directed towards the self. This self-directed aggression creates feelings of despair and guilt. Freud put forward a theory of personality suggesting that it consisted of three conflicting parts. The id, which you are born with, is greedy and unsocialized. The ego is the public part of the personality and develops when you are a toddler. The superego is the third and final aspect of the personality to emerge. It provides our moral code, or conscience. Freud thought that throughout life, the id and superego were in conflict. The ego attempts to maintain balance. Freud suggested that the symptoms of what we now call bipolar disorder can be explained by the interaction between parts of the personality. During the depressive stage, the superego gains control, making the individual feel guilty and worthless. The ego tries to assert itself and gain supremacy. This is what causes the manic phase. Eventually the superego takes over again and the individual is thrown back into depression. Davison and Neal, 1990, found no direct evidence that depressed people interpret the loss of a loved one as desertion or rejection. Most of us will have experienced some form of loss in childhood and yet we do not experience mood disorders later in life. However, the impact of a very traumatic childhood is acknowledged as one of the possible causes of psychological difficulties in adult life. Evaluative comment. Many critics point to the lack of scientific evidence for the psychodynamic approach. In terms of depression, some research indicates that early loss can contribute to depression in women. Brown and Harris, 1978, undertook a survey of housewives in Camberwell, London. They found one factor that might make a person more vulnerable to depression was the early loss of a mother. However, this was only one of a number of vulnerability factors identified. Other problems, such as lack of employment, or having 2 or more children under the age of 5, also had an effect. The impact of early loss may have more of an indirect influence. Psychodynamic treatments. Freud was one of the first practitioners to suggest the talking cure, which he called psychoanalysis. The aim of the treatment is to help the patient, or client, to gain insight into their repressed conflicts, hidden in the unconscious mind. Freud believed this could be achieved by using a technique called free association. The client is asked to talk about anything that comes into their mind, without editing or censoring it. This can be quite difficult to do, because in everyday conversations we are constantly monitoring what we say, making sure it makes cognitive treatments. Beck, 1976, developed a therapy to challenge the negative schemas of the client. First, the client will be assessed to discover the severity of their condition. The therapist will establish a baseline, or starting point, prior to treatment, to help monitor improvement. The therapist must make the client aware of the relationship between thought and emotion. For example, if you think you are stupid, it may make you feel sad. If you feel sad, you will not enjoy what you are doing. Thoughts influence emotions and behavior. To feel better, you must think positively. The client is asked to provide information about how they perceive themselves, the future, and the world. The therapist would use a process of reality testing. For example, if the client says, "I'm useless, I always fail," they will be asked whether, in reality, they have been successful at something. The client's beliefs are directly challenged and they are made aware of their negative views. The therapist may ask the client to do something to demonstrate their ability to succeed. In this way, irrational ideas can be replaced with more optimistic and rational beliefs. Evaluative comment. Cognitive therapy has been very successful in treating unipolar depression. However, the client must be motivated and committed to change. Some people may find the approach too directive and confrontational. Beck acknowledged that as well as changing negative thoughts, the client must also be encouraged to alter their behavior. He would set clients' homework, or activity assignments. Clients are encouraged to interact with others, to help them feel good about themselves. This combination approach is called cognitive behavior therapy. Effectiveness of treatments. There are many different treatment methods available for mental health problems. Each has limitations, however. The effectiveness of the treatment may depend on the psychological attributes of the patient. For example, a motivated person, who likes to think their way through problems, may benefit from the cognitive approach. Moore, 1995, looked at a group of patients whose therapy had been unsuccessful. He found that patients who were poorly motivated, who thought that therapy would be easy, or who had poor interpersonal skills, were most likely to report negative outcomes. A second factor we have already identified is the client-therapist relationship. Study 4. The aim. Sloan et al., 1975, wanted to identify the main factors contributing to recovery from depression. Method. He conducted a study on two groups of patients who had benefited from either behavioral or psychodynamic therapy. Each group was asked to identify the main factors contributing to their recovery. Result. Both groups reported being able to talk to a sympathetic and encouraging person as an important part of their therapy. Conclusion. The personality of the therapist may be as crucial as the type of therapy given. Drug treatments are not dependent on the strength of a therapeutic relationship. Also, patients do not have to feel personally responsible for a chemical imbalance taking place within the body. Consequently, some patients may be better suited to this form of treatment. Sterling and Helliwell, 1999, suggest that the severity of the depression should be taken into account when assessing which treatment to offer. Therapy may be useful for patients with less severe or persistent depressive states. For long-term clinical depression, such as bipolar depression, it is likely to be less effective than drug treatments. Establishing which treatment is the most effective is as problematic as trying to identify a single cause for depression. Humans are complex, and the way forward may be a combination of the current treatments available. Schizophrenia. Schizophrenia is not, as many people think, a split personality. The split in schizophrenia occurs between the person's thought processes and reality. It is categorized as a psychosis and affects 1 in 100 people, with equal numbers of males and females. Before the 1950s, many people with schizophrenia spent most of their lives in psychiatric hospitals. This is known as institutionalization. New treatment methods have changed this. About 25% of sufferers will get better after only one episode of the illness, 50 to 65% will improve, but continue to have bouts of the illness. The remainder will have persistent difficulties. Sterling and Helliwell, 1999. Classification. There are 4 main types of schizophrenic disorder: disorganized, catatonic, paranoid and undifferentiated. Each of these is described briefly below. Disorganized schizophrenia. Symptoms include thought disturbances, an absence of expressed emotion and a loss of interest in life. The person's behavior is generally disorganized and not goal-directed. Catatonic schizophrenia. Catatonic schizophrenia is diagnosed if the patient has severe motor abnormalities such as unusual gestures or use of body language. Sometimes patients gesture repeatedly, using complex sequences of finger, hand and arm movements, which appear to have some meaning to them. Paranoid schizophrenia. Delusional symptoms and hallucinations are present. However, the patient remains emotionally responsive. They are more alert and verbal than patients with other types of schizophrenia. Undifferentiated schizophrenia. This type is diagnosed when the patient shows symptoms of schizophrenia but does not fit into the 3 other types. Symptoms and diagnosis of schizophrenia. Schizophrenia is a psychosis that is categorized in both the DSM and ICD. The symptoms are divided into 2 groups. Some symptoms are rare in normal, everyday experiences. These are known as positive symptoms. Other symptoms are much less dramatic and can be experienced in everyday life. These are known as negative symptoms. A person may also be affected by secondary symptoms such as depression, as a result of the difficulties of living with the disorder. Davison and Neal, 2001. Positive symptoms. Hallucinations. The most common hallucination is an experience of hearing voices. People with schizophrenia can hear their own thoughts, but also report other inner voices. The voices may appear to talk to each other, as well as talking to them. The thoughts can be so loud that the sufferer believes other people nearby can also hear them. This is known as thought broadcasting. The The voices may appear to come from outside, for example, from the television. Visions and hallucinations of smell, taste or being touched can also occur, although they are less common. Delusions. A delusion is a particular kind of unusual belief, which is experienced without any evidence to support it. Some sufferers experience paranoid delusions where they believe that others are trying to harm them. Others have delusions of reference. This is where you start to see special meanings in ordinary events. For example, you may believe that a radio program is specifically about you. Grandiose delusions are where the sufferer has an exaggerated sense of power, knowledge or identity. For example, believing that they can save the world. Thought disturbances. A person with a thought disturbance may appear incoherent. It is difficult to understand what they are talking about, because they seem to jump from one topic to the next. There can also be a lack of concentration. Some people describe their thoughts as misty or hazy. They cannot remember what it is they want to say or do. Negative symptoms. There may be a lack of energy, and a loss of interest in life. It can be difficult to wash or tidy up, or to keep clean. This is known as avolition. The person may also stop showing any emotion and appear lifeless. They may stare vacantly and speak in a flat, toneless voice. This is called flat affect. While the negative symptoms are much less dramatic, they tend to last for longer than the positive symptoms. Ho et al. 1998, found that the presence of many negative symptoms is a strong predictor of a poor quality of life, 2 years after the initial diagnosis. Secondary symptoms. These symptoms are thought to result from the consequences of having the disorder. Some sufferers report depression, or an inability to maintain existing relationships or make new friends. It may be difficult to find and keep employment. The extent to which somebody is affected by secondary symptoms may depend on their support systems, how quickly they were diagnosed and how effective their treatment is. Diagnosis. In Britain, one or more positive symptoms must be present for a diagnosis. To be made, Sterling and Helliwell, 1999. Alternatively, 2 negative symptoms may also lead to a diagnosis. The symptoms must have been apparent for at least 1 month. The illness usually occurs gradually and has 3 phases. Schizophrenia rarely starts before the age of 15, and although it affects men and women equally, there are differences in the age of onset. Men usually notice symptoms in their late teens or early 20s. Women are often affected later, in their 20s and 30s. Someone with schizophrenia may not realize they are ill and can refuse treatment when they need it. As a result, they can be admitted to hospital against their will under the Mental Health Act. This should only happen if their health is at risk, if they are a danger to themselves, or if they may be a danger to others. Evaluative comment. There are many different symptoms and types of this disorder. 2 people may be diagnosed and yet have completely different characteristics. Romy and Escher, 2000, claimed that hearing voices is not necessarily indicative of a psychotic illness. They surveyed 15,000 non-schizophrenic people and found that between 10 and 15% had experienced voice hearing, often the voice of a loved one after bereavement. Explanations and treatments for schizophrenia. The biological approach. Genetics. Like unipolar disorder, research has focused on twin studies. Gottsman and Shields, 1972, found that the concordance rate for schizophrenia in MZ twins was 48% compared to a 10% rate for DZ twins. Study 1. The Aim. Heston, 1966, investigated the role of genetics in schizophrenia. Method. He compared 47 adopted children whose biological mother had schizophrenia with a control group of adopted children with no history of schizophrenia in their biological family. Result. None of the controls was diagnosed with the illness. 16% of the offspring of schizophrenic mothers were diagnosed. Conclusion. This indicated that inheritance does play a part in the disorder. Evaluative comment. These studies show that the cause of the illness is not wholly genetic, and indicate an inherited predisposition. The diathesis stress model of mental illness suggests that inheritance can put people at risk. However, stress may also play a part. It has also not been possible to identify whether a single gene or several genes are implicated or how they influence the emergence of symptoms. Research in this area continues but as yet offers no method of treatment. Biochemical explanations. An excess of the neurotransmitter dopamine has been implicated in schizophrenia. Davison and Neal, 2001. Dopamine is a substance that is known to be active in the limbic system, an area of the brain governing emotion. Evidence to support the dopamine hypothesis comes from the following sources. the effects of drugs used to treat patients with Parkinson's disease. This degenerative brain disease is known to be caused by a decrease in dopamine. Drug treatments to increase dopamine levels in Parkinson's patients can have side effects similar to the symptoms of schizophrenia. Antipsychotic drugs, which reduce the levels of dopamine, are effective in reducing the symptoms of schizophrenia. Kimball, 1988. Postmortems conducted on schizophrenic patients show high levels of dopamine in the brain. Iverson, 1979. Amphetamines and cocaine increase dopamine levels. Some drug users experience schizophrenia-like symptoms. Davis, 1974. Evaluative comment. Again, there are problems in establishing causality. Does excess dopamine cause schizophrenia, or does the illness have an effect on dopamine levels? Like bipolar depression, it may be that receptors in the brain of a person with schizophrenia are more sensitive, rather than the level of neurotransmitter. Sterling and Helliwell, 1999. Further biological research has concentrated less on biochemical effects and more on possible structural abnormalities in the brain. Stevens, 1982, showed that there are differences in eye movement with schizophrenic patients. These kinds of differences are usually seen in patients with brain damage. Antipsychotic drug treatments. The most important development in the treatment of schizophrenia has been the introduction of antipsychotic drugs. These drugs can reduce the positive symptoms of psychosis. In 1954, a drug called chlorpromazine was introduced. It blocks dopamine receptors in the brain. This means that neurons do not respond to dopamine. The drugs usually weaken positive symptoms gradually over a few weeks, and thought processes become clearer. However, side effects can occur, including tremors, drowsiness, and weight gain. About 1 in 20 people experience permanent movements in the tongue and mouth. Newer drugs called atypical antipsychotics work on a wider range of neurotransmitters, including serotonin. They have fewer side effects and can help reduce negative symptoms. Both types of drugs can be taken daily by mouth or by injection every 3 to 4 weeks. Evaluative comment. Drug treatments were seen to be a major breakthrough in the treatment of schizophrenia. They have reduced the number of long-stay patients in hospitals and enabled sufferers to live in the community. However, some patients do not respond and find the side effects, such as tremors or drowsiness, difficult to cope with. Also, drug treatments are not a cure. If the sufferer stops taking the medication, the symptoms can return. Psychodynamic approach. Freud believed that schizophrenia emerged due to conflict between different parts of the personality. In adult schizophrenia, the ego is overwhelmed by either the id or the superego. As a result, the ego, or public part of the personality, regresses back to infancy. The individual has delusions of self-importance, very like the demanding and unsocialized behavior of a baby. Fantasies become confused with reality, as the ego tries to get control. Hallucinations and delusions will then emerge, as the ego struggles to regain a sense of reality. Evaluative comment. Unfortunately, there is no scientific evidence to support Freud's ideas on schizophrenia. Sterling and Helliwell, 1999, point out that schizophrenic behavior is not similar to infantile behavior. Research has not found a correlation between early childhood experiences and a subsequent diagnosis. However, the role of family members has been implicated in socio-cultural explanations, as we will see later in this chapter. Psychodynamic treatments. Freud didn't use psychoanalysis with schizophrenic patients. He thought they were incapable of forming a close interpersonal relationship with the therapist and the technique would therefore fail. However, Sullivan, 1929, pioneered the use of psychotherapy with hospitalized patients. He too believed that schizophrenia was a regressive process. The sufferer returns to a childlike state, because they experience childhood trauma and are unable to handle the stresses of adult communication. Sullivan thought that a trusting relationship could be slowly built up with the patient, which would eventually lead to success. The therapist could help the patient to develop a stronger ego, by examining their relationships from the past. Evaluative comment. Critics have pointed out that Sullivan's patients were only mildly disturbed and may not have been diagnosed with schizophrenia using current criteria. A review of psychotherapy undertaken by Katz and Gunderson, 1990, found that the technique may even prove harmful for patients with positive symptoms. The behavioral approach. The behavioral approach explains schizophrenia as a learned response. Ullman and Krasner, 1969, argue that people will behave in a schizophrenic way if they are reinforced for it. The disorder develops through a process of operant conditioning. Bizarre behavior gains attention from other people, so may be reinforced more than normal behavior. Through a process of social learning, patients in hospitals may also observe and imitate the behavior of other schizophrenics. Evaluative comment. This approach does not really explain how schizophrenic symptoms emerge in the first place. For example, why a person would report hearing voices rather than adopting any other kind of behavior. Critics argue that it oversimplifies a complex and distressing condition by reducing it to an attention-seeking strategy. However, social learning theory can be used to explain how patients' symptoms can multiply after diagnosis, because hospitalization increases the amount of social contact with other patients displaying unusual behavior. Study 2. The Aim. Paul and Lentz, 1977, investigated the effectiveness of operant conditioning by reinforcing appropriate behavior with schizophrenic patients. Method. They set up a token economy system in a hospital ward. The patients were given tokens as a reward each time they behaved appropriately. These could be used to purchase meals and small luxury items. For example, making your bed earned a token. Patients also received individual behavioral treatments tailored to their own needs. Their progress was followed up every 6 months, for a period of 6 years, by interview and direct observation. Result. Paul and Lentz found that both positive and negative symptoms were significantly reduced, leading to more hospital discharges when compared to a control group. The research also found that only 11% of patients continued to need drug treatment, compared to 100% of the control group. Conclusion. Operant conditioning is an effective means of treating people with chronic schizophrenia. Behavioral treatments. Evaluative comment. While this is a very impressive study, Paul, 1981, later concluded that the token economy was useful mainly in gaining the attention of the patients. However, the most important factor in their recovery was the social skills training given by the staff. The training is used to teach people the right way to behave in a wide variety of social situations. Patients are helped through role play, tuition and experience to develop new skills and consolidate existing ones. The cognitive approach. Schizophrenia is characterized by disturbance in language, attention, thought and perception. This has led cognitive psychologists to explain it as a result of faulty information processing. We are constantly bombarded with information from the outside world, yet our information processing abilities are limited. As a result, the brain selects which information to pay attention to, and ignores the rest. Auditory selective attention is the process by which the brain selects which sounds to respond to. Pickering, 1981, proposed that catatonic schizophrenia may be caused by a breakdown in auditory selective attention, making social interaction increasingly difficult, as the individual is overloaded with auditory information. Pickering believes that withdrawal from the world is the only way for catatonic schizophrenics to keep sensory stimulation at a manageable level. Frith, 1992, suggested that schizophrenics fail to monitor their own thoughts, misattributing them to the outside world. When a person hears voices, it is actually their own inner speech being misinterpreted. Evaluative comment. The cognitive approach explains how information processing is affected in schizophrenia but does not provide an explanation of what causes these cognitive changes. The disorder is typically diagnosed in adulthood and, as yet, there is no scientific evidence to link childhood difficulties in information processing with later onset of schizophrenia. However, the approach is currently being used to develop new strategies of coping with the disorder, and research in this area is ongoing. Cognitive treatment. This is a relatively new development in the treatment of schizophrenia and has caused some controversy. Some practitioners believe that voice hearers can be helped to bring the voices under their control, using cognitive behavioral techniques. The idea has led to a renewed interest in the role of psychotherapy. However, the emphasis is on controlling thought processes rather than uncovering unconscious wishes. Bentel et al., 1994. The process begins by asking the patient to focus on the nature of the voices they hear, for example, thinking about their tone, or whether they are male or female. They might also find external ways of focusing, by drawing pictures of the different voices. Therapists help the patient to recognize that the voices represent part of their own thought processes. An evil voice may represent their own desire for self-harm. Patients are also encouraged to develop strategies to protect them against the wishes of these inner voices. For example, relaxation techniques, talking to supportive others, or only choosing to pay attention at a certain time of day. Evaluative comment. Many psychiatrists are concerned that the approach may encourage and support delusional thinking in their patients. Paying attention to the content of voices may result in the client doing what the voice instructs, rather than controlling it. However, Romy and Escher, 2000, disagree, claiming that focusing on voices actually reduces the likelihood of harm to the self or others. Sociocultural explanations. Labeling. Sash, 1962, claims that schizophrenia does not exist. He believes it is a way of classifying people whose behavior is bizarre and difficult to control. Mental illness is simply a label used to exclude people who don't conform. Sheff, 1966, argued that receiving a psychiatric diagnosis creates a stigma or mark of social disgrace. The label mental illness creates expectations from the patient and others. As a result, the behavior of the patient may change towards those expectations. The diagnosis thus creates a self-fulfilling prophecy. Study. The Aim. Rosenhan, 1973, provided a powerful example of the effect of labeling. Method. He asked 8 psychologically healthy people to arrange appointments at different hospitals. They were to complain that they could hear a voice in their head, which said words like thud and hollow. All 8 pseudo-patients were admitted to hospital. 7 were diagnosed with schizophrenia. Rosenhan instructed the participants to act normally once they were in hospital, not to take any medication given, and to try to convince staff that they were sane. They were also asked to observe and record their experiences on the ward. Result. The pseudo-patients were kept on the ward for an average of 19 days. The longest stay was 52 days. All but one of the participants were released with a diagnosis of schizophrenia in remission. None of them managed to convince medical staff that they were sane. The pseudo-patients observed how normal behavior was viewed as schizophrenic. For example, queuing for lunch was described by one psychiatrist as oral acquisitive syndrome. The participants were often ignored by staff, creating a sense of powerlessness and fear. Other patients did recognize normality and asked the pseudo-patients if they were reporters. Conclusion. Perceptions of patients are affected by the labels they have been given. Evaluative comment. This study contributed to a revision of methods for diagnosis and patient care. It also contributed to the debate surrounding institutionalization, which we will consider at the end of the chapter. However, there are ethical problems, as deception was involved. Labeling theory has provoked many practitioners to re-examine their own expectations. Even so, distressed, disoriented and deluded people, with a range of symptoms, do exist and require help. The theory does not provide any viable means of treatment for these people. Family dysfunction. The importance of family relationships has been put forward as a possible explanation for schizophrenia. The approach is sociocultural because it does not look to the individual sufferer. It concentrates on the social and cultural environment. Early theorists, influenced by Freudian ideas, thought that a schizogenic mother, who was cold, dominant and created conflict, caused schizophrenia to emerge in the child. These mothers were said to be rejecting, overprotective, self-sacrificing, moralistic about sex and fearful of intimacy. Bateson et al. 1956, thought that faulty communication within families was a possible cause. They called this the double bind. Parents place children in a no-win situation by giving them contradictory messages. For example, a father might ask for a hug and then push the child away, telling him they are too old for cuddles. This theory suggests that children will become confused and lose their grip on reality. They will begin to mistrust their own thoughts and feelings. Evaluative comment. There is no clear evidence to support the claim that family relationships create schizophrenia. Klebanoff, 1959, has argued that strained family communication may be the result of dealing with an already unusual child. However, some studies have indicated a family role in the recovery of already diagnosed schizophrenics. Study. The Aim. Brown et al. 1966, investigated the impact of family relationships on the recovery of schizophrenic patients. Method. They conducted a 9-month follow-up of schizophrenic patients discharged from hospital. Interviews were conducted with family members. The conversations were rated for the number of critical comments or hostility towards the patient. Result. Brown et al. Found that families who were high in expressed emotion, EE, were critical of the patient. 58% of patients from high EE families returned to hospital for further treatment, compared to only 10% of those from low expressed emotion families. Conclusion. Family relationships can affect the recovery rates of people with schizophrenia. Effectiveness of treatment methods. At the moment, the most effective treatment for schizophrenia is the use of antipsychotic drugs, although, as we have already noted, they can have unpleasant side effects for patients. Behavioral treatments have been successful in changing the behavior of long-term schizophrenic patients, but they do not remove cognitive symptoms, like voice hearing or delusions. Traditional psychotherapy has been largely discounted as a treatment method. However, researchers are investigating the effectiveness of more cognitive therapies. These techniques may be useful in providing coping strategies for patients to successfully manage their symptoms and reduce the likelihood of relapse. Research, Bentel et al., 1994, suggests that cognitive therapy may be most effective for patients experiencing their first episode of schizophrenia. All of these treatments focus solely on the individual and ignore the impact of their social and family situation. Mental health practitioners may need to broaden their focus to this wider community to find ways to improve recovery rates. Institutional care and community care. Because there were no effective treatments available, until the 1960s, many patients spent a very long time, in some instances 30 years or more, in state mental hospitals. While this meant that they were under medical supervision and being physically looked after, it also produced additional problems. For example, patients in hospitals can observe and imitate the behavior of other schizophrenics. Also, the hospital ward provides little information about how to survive and fend for yourself in the outside world. This led to many patients becoming institutionalized. They did not have the necessary social skills to succeed outside the institution. With the advent of new drug treatments, the incidence of long-term care has been significantly reduced. Many mental hospitals have now been closed and replaced by community care programs. Community care aims to provide the patient with continued support outside the hospital ward. Psychiatric nurses visit patients at home to monitor them and help sort out problems with medication. Occupational therapists can give advice on building important social skills. The patient may attend hospital day clinics and see a clinical psychologist occasionally. They can also attend day centers within the community, where they can meet with other people. Some areas also have work projects to help people get back into employment. Patients may also be provided with supported accommodation where they have their own flat or bedsit, but a member of staff also lives on the premises. Research has tried to evaluate the impact of community-based treatment programs as compared with standard inpatient care. Study. Aim. Stein and Test, 1980, wanted to find out if community care was better than hospitalization for people with schizophrenia. Method. They compared two groups of 65 patients. Participants in one group received standard inpatient treatment. The second group received a training program to enable them to live in the community. The following aspects were examined. The availability of resources to the patients, such as food and shelter. Training in basic social and community skills. Reducing dependency on family or institutions. Support and education of key carers in the patient's life. Developing a social network. Result. During the first 12 months of the study, 58 of the inpatients had been readmitted for further treatment, compared to only 12 of the patients who received the training. Unfortunately, when the training program ended, many patients from the community care group were later readmitted to hospital. Conclusion. Care in the community can be successful, provided patients are given constant support. However, community care is not a cure, and patients will continue to experience symptoms. Shepard, 1998, has argued that community care can be successful if specialist teams, made up of psychologists, occupational therapists, social workers, psychiatrists and nurses, have small caseloads of 10 to 15 patients. Help should be made available for clients both day and night. Continuity of care workers is also important. Evaluative comment. Critics of community care are concerned that there are differences in the quality of service provided across the country, depending on available funding in local areas. Some patients simply slip through the net, and do not receive the care and attention they need, with very negative consequences for the individual and others. Institutionalization does have some positive consequences. A controlled environment allows the close monitoring, support and treatment of those suffering with a mental illness. It can prevent harm to the self or others. Final note. This area of the specification can be useful to return to when you begin the Debates in Psychology section of the course. For example, the biological approach adopts a nature argument to explain mood disorders and schizophrenia, whereas the behaviorist approach supports an environmental cause. Psychodynamic approaches are idiographic, whereas behaviorism or biological explanations adopt a nomothetic approach. The mind and body debate can also be considered by comparing the psychodynamic approach to the biological approach.